Hello, everyone. Once again, good evening to all of you. Warm welcome to day two of the scientific sessions of the Oral Cancer E-Conclave. I, on behalf of Sterling Cancer Hospital, Foundation for Head and Neck Oncology and Innovative Cancer Care, thank all the participants who are here with us on different social media platform. I'm sure that we are going to learn a lot more new things on today's session because it is going to be a great discussion with a lot of panelists here on board and elite doctors from across the country who have joined us to impart us grave knowledge about the subject. I once again thank all the partnering organizations and the representatives who are here with us today for tirelessly working to make this event really successful. I thank all the chairperson speakers and panelists who have given us their valuable time on this Sunday, on this beautiful Sunday, to teach us to talk about the subject and to really help our young doctors, our budding entrepreneurs, to learn more things, to enhance their practices as well at the same time. So today, without taking much of the time, I'll quickly invite Dr. Pooja Nandwani. She is senior consultant and head at Sterling Cancer Hospital, who is also the executive committee member of Association of Radiation Oncologists of India and joint secretary for Indian College of Radiation Oncology. Please chair the session for the evening.
Hello, good evening, everyone. It's my pleasure to be here again on the second Sunday, and we had a very interesting discussion last Sunday, and I hope now this today's session with more and more involvement of the clinicians and more interesting discussion would be a great feast for everyone today. So, without much waste of the time, I would first of all invite the first chairperson of this session, who is Dr. Sameer Patel. He is the principal professor and head of orthodontics at the Singha Dental College and Hospital, Pune. He's also been the Senate member at the Maharashtra University of Health Sciences, Nasik, and has various important positions at the various important association in the college. And I welcome you, sir, at this conclave. And it is also my privilege to invite the first speaker, Dr. Devendra Choukar, who is the professor and head division of head and neck oncology at the Tata Memorial Hospital, Mumbai. So over to Dr. Devendra Choukar.
All right. At the outset, I would like to thank the organizers for inviting me, especially Somesh and FHNO Vikram for having me. But Somesh gave me a difficult talk. I would have loved to speak on management, but he's told me to talk on how do you define early oral cancer. So let's see how we can define early oral cancers both clinically, radiologically, and pathologically. Right. So sitting in a tertiary cancer, we are quite that we get lesions which are frankly malignant, and we don't have to scratch our heads thinking whether this is malignant or otherwise. But outside in practice, at the primary physician care level, you will get a variety of lesions in the oral cavity. Some of them are benign or inflammatory, and that is the decision that you have to make. Which one is notorious? Which one may be cancer? And which one you can stop. And that's a decision to do. As can be seen by the study, where 50 dentists were shown lesions, photographs of lesions, and differentiate between pre-malignant oral squamous carcinoma and benign or inflammatory lesion. And they did it with a very poor sensitivity and specificity, and it was not better than random guessing. So it is quite difficult when you get these different lesions to distinguish which are innocuous lesions and which are the notorious ones which you will need to then further treat. And to do that, we have a host of aids that are there in the market. The market is full of such adjuncts, as we call it, to help us make a diagnosis, to help us first early detect the cancer. In the second thing, they help us do the biopsy or help us establish from which area of the lesion we need to take a biopsy. And third, more recent use of these adjuncts is in attaining oral margins. So I'm not going to go through all the details. This is a different talk by itself, but there are various adjuncts that are available. They can be vital dyes. It could be a brush biopsy, a quick brush biopsy where you can quickly brush and get histological confirmation. You have equipment which look at the absorption and reflection of and the difference between absorption and reflection of the normal versus the cancerous mucosa. You have differences in fluorescence between the normal and the abnormal. And you have recently the narrowband imaging and optical coherence tomography, which kind of gives you a pathological picture of these lesions. So these are nowadays used as an adjunct to establish a diagnosis of oral cancer, help us identify which area we need to biopsy, and more recently, as I said, help us determine margins. Unfortunately, all of these adjuncts are still in the experimental stage. Most of them suffer from high false positive values, give rise to unnecessary anxiety in patients, and hence they have not yet been in routine clinical use. So till we get a good trial which shows us that these adjuncts are good, we have to fall back on the good old methods of our history, inspection, and palpation. So how do you decide whether to or whether to not to treat a particular oral cancer? It depends on the location of the cancer, history of the lesion, whether it's on the site of previous malignancy, history of tobacco chewing, and etc. Location of the lesion, size of the lesion, and texture of the lesion. So depending on all these good old history and palpation methods and inspection methods, we do decide the treatment of these oral cancer lesions. Coming to today's topic of early oral cancer, as you all know, is defined as T1, T2, and 0 cancer. And now, last Sunday, as we heard, we had a lovely talk on AJCC classification of oral cancer. And the only thing that has been incorporated in the AJCC classification, which is new, is the depth of invasion. So if it is now more than 10 millimeters, it is no more early cancer and it is classified as advanced cancer or T3. It upstages that cancer into T3. After this staging system came into being, the radiologists rushed in, and we had a lot of publications looking at radiology to kind of tell us the depth of invasion of oral cancer. And I know there's a talk after this, so I'm not going to go into details because of this measurement of a depth of invasion of oral cancers. It differs whether the lesion is small, the lesion is ulcerative, or the lesion is large. And I think that we covered the next topic. But the radiologists now started telling us what the depth of the lesion was. Now take a minute back and think whether you really need preoperatively to look at the depth of these lesions. If you look at the publication which changed the AJCC classification, and I've heard of many talks, people who have designed the AJCC tell us that you pinch these tumors. Now, pinching these tumors may be okay in oral cancer, but is it possible? Can it be applied for palatal lesions? Is it possible to do that for lesions that are over the alveolus? Really change your surgical plan. Saying that it's a 7 millimeter or 8 millimeter depth, does it change your surgical plan? They thought it did, because if the depth was larger, then it was probably an indication for neck dissection. Now that doesn't hold true, because the next slide I'll show you. It is more important, this classification of more than 10 millimeters in pathology. And the depth doesn't hold true now clinically, because as we know in early oral cancer, you need to do the neck irrespective of the depth of the oral cancer, and that is shown to save lives. Now, another point I'm making, and the point it's probably useful, the depth of invasion, as I said earlier, in the pathology, in the post-operative period. Now, if it is more than 10 millimeters, you upstage the disease into T3, and then you would probably give the patient a post-operative radioactive iodine. So it is upstaged from early oral cancer to advanced oral cancer. And that is the importance of this AJCC. This has only, kind of legitimized what we were following all these years. Because if you look at the protocol that Dr. Cruz established way back in 2004, he had actually said that you need to give RT for lesions that are about 10 millimeters. So I think probably we always knew that anything that is large and deep probably doesn't behave like early oral cancer and behaves more like an advanced oral cancer. And that's why probably he, at that time, also had included radiation therapy for early oral cancers that were more than 10 millimeters. And now in 2018, the JCC has legitimized this feeling that we had all along. In spite of this, in spite of us knowing that we need to do neck dissection for early oral cancers, there are a lot of publications which look at various investigation modalities trying to establish the incidence of neck metastasis in early oral cancer. Now, this is unnecessary again because you need to anyway operate the neck. It is good if you are not giving surgical treatment. For non-surgical treatment, if you can radiologically pick up nodal metastasis, that will upstage the disease from early to again advanced as N1. and then you may add chemotherapy to radiation therapy. But for a surgically treated disease like the oral cancer, you need not rush in to look at which investigation is the best for you to tell me whether or not the neck is involved. The only new addition now is the sentinel node biopsy, and that can be taken as a diagnostic tool as well. It has a good sensitivity and specificity and overall accuracy in determining whether the neck is positive or not. And this not only is diagnostic, but also can be therapeutic, because if that is negative, then you may not do the neck dissection, and that is proven in this equivalence randomized trial of sentinel node biopsy versus neck dissection. So you can do less than a neck dissection, and theoretically probably save the patient the morbidity of neck dissection. They have not looked at shoulder dysfunction yet in a great detail, but this study also told us that the shoulder morbidity was less, but shoulder morbidity needs to look at. So early oral cancer, AJCC, yes, it guides you, but your surgical plan doesn't change. You have to operate the primary, you have to operate the neck. Sentinel node biopsy is exciting and probably may replace elective neck dissection. The only scenario where MRI helps us is probably when the lesion is small, because if you look at the MRI, if the lesion is extremely small, then the MRI does not pick up. If the MRI is not showing the lesion, then the lesion is probably less than 4 millimeters in depth. And this is what we get from radiological studies. So if a patient, I'll give you a scenario. Many a time we are referred patients who come to us with an excision biopsy, and we don't know whether to operate the neck or to observe, put the patient under anesthesia again. So if you have a preoperative MRI which shows no lesion seen, then probably the depth of that lesion was less than 4 millimeters. So this is a rough guide to tell us whether the lesion is thin or thick. But as I said earlier, we need to operate all the neck irrespective of what the imaging modality tells us, whether it's N+ or N0. So from clinical, let's go on to radiological inspection, and I'm not going to cover it in detail. I'm just going to tell you 2 or 3 points where we use radiology. These are the areas in early oral cancer where we define whether it's early or advanced by looking at radiology. Tongue cancer, buccal cancer, which is juxtaposed to the mandible, a small lesion in the retromolar trigon, a T1, T2 lesion in the retromolar trigon, and a small lesion in the hard palate. These are the 4 areas where you would take the help of radiology to tell you, and we'll go one by one. For a tongue cancer, yes, you would like to know whether this innocuous appearing superficial lesion is actually superficial or it's extremely deep, going right up to the midline, which tells you that this, which guides your surgical excision. So in majority of the cases in tongue cancer, unless it's a small, very superficial lesion, we would like to get an imaging done. For gingivobuccal sulcus cancers, which are juxtaposed to the mandible, you want to know whether the mandible is involved. You want to know, if it is involved, what is the extent of involvement, because you would want to do a marginal, you want to decide whether you can do a marginal mandibulectomy or not. And you would like to know the route of tumor entry. And I'm going to talk a couple of slides on that. So yes, we have a lot of studies which looked at which is the best modality to detect bone invasion in early oral cancer. And CT scan in all the studies, including the one which I presented now, seems to score the best. CT and MRI have equal values, but for bone invasion, CT has an overall accuracy which is better than all the other modalities. So when you are looking at bony invasion, do a CT scan. A couple of slides on marginal mandible. I know this is not my mandate, but I couldn't, resist the temptation of putting something on management. There is a slight difference in early cancers, how they invade the mandible. In the floor mouth, they invade at the line where it at the point of abutment of the attached and the reflected mucosa. And that is why when you have a floor mouth lesion, which is small, and you want to remove the mandible, though the mandible is not involved, they juxtapose with the mandible, always do a oblique marginal mandibulectomy. Because if you do a horizontal mandibulectomy, you will get a positive soft tissue in the floor of the mouth. As opposed to the buccal cancers, where the route of tumor entry is at the dental sockets, you can get away by doing a horizontal mandibulectomy. So these are a couple of points for early oral cancer, which are juxtaposed with the mandible to decide when to do what type of marginal mandibulectomy. Going on, as I said, retromolar trigon, always get a radiological evaluation done. You would want to know whether this is the tip of the iceberg, both in RMT and the hard palate. You would want to know whether this is the tip of the iceberg or there is some disease lurking behind in the infratemporal fossa, or up in the palate. In case of a palate, is it involving the bone, upstaging it to T4? So these are the 4 indications of a radiological, where you define whether it's early. When it is clinically early, you need radiology to tell you whether it's really clinically early, or whether radiology is upstaging the disease from T1, T2 to more advanced T3 and T4 disease. More importantly, in tongue cancer, it is the pathological definition that is important for tongue. So T1, T2 clinically, your management doesn't change too much. You just do the surgery, get good, adequate, wide margins, and you do the neck dissection. What is important is that in spite of you doing a good surgery, 15 to 20% will require adjuvant therapy, and 10 to 15% will fail. Okay, so this is where the pathological definition of early oral cancer comes in. And we know for adjuvant radiotherapy. For example, stage 3-4, which is not the case in this, unless the depth of invasion is more than 10 millimeters. If you get a positive margin, if you find nodes at your supraomoid neck dissection, and you find extracapsular spread, these are absolute indications. But in early oral cancers, there are other soft indications, and we don't know the exact definition or exact use of these soft indications as far as postoperative radiation therapy is concerned. And these soft indications include lymphovascular invasion, perineurial invasion. There is something which is now reported, the worst pattern of invasion, and tumor budding, lymphocyte infiltration. There are a lot of other soft, you'll find a lot of publications on these, looking at whether individually these factors. The most common after depth of invasion, the publication that you see is perineurial invasion. The perineurial invasion is of different types. It is generally where you see tumor cells within the 3 nerve sheaths, intraneural or extraneural. I'll come to that. But the most definition by the pathologist is when they see the tumor cells in close proximity of the nerve, which is involving at least 33% of its circumference. So when that is the case, the pathologist will report it as presence of perineurial invasion. Now, as I said, again, there are a lot of definitions. Whether we want to look at it, whether the caliber of the nerve which is involved is small or large, that is less than a millimeter or more than a millimeter. The pathologist would like to report whether it's intratumoral or extratumoral, because if it is extratumoral, then it is usually along the big name nerve and the prognosis is poor. Whether the presence is intraneural or not, whether it is along the name nerve, which is then called as perineurial spread rather than perineurial invasion. The 2 terms are different. Invasion is different from perineurial spread. Perineurial spread is said when it is detected on radiology, the spread along a named nerve. And also the pathologist will report the focal density, how much of the nerve, how many nerves are involved in the particular slide. So all these are important, and you must ask a pathologist to define all this, because perineurial invasion, now there are a lot of reports saying that is probably may be an independent factor that requires radiation therapy. This study by Chin, they looked at 88 patients, 23% had PNI, and they reported that PNI was an independent indicator of adjuvant RT in the absence of nodal disease. We looked at our cohort of patients, more than 1,500. Again, incidence was around the same, 20.3%. And PNI, again, was an independent predictor for disease-free survival and overall survival in patients who were node negative. So PNI probably may be going in ahead in the AJCC, maybe the next AJCC classification may use PNI if we get more, as we accumulate more and more evidence with regards to this. The other soft indicators, well, there are hosts of them. Apart from perineurial, you have worst pattern of invasion, you have lymphocytic infiltration, as I said, tumor budding, and people have tried to put all of them and tried to get a staging system. Whether can we, combine these factors and get kind of a score which tells us that this is going to be worse if the early oral cancer has this 2 to 3 indications that you may need to add postoperative RT. And one of the commonly reported ones is the Margaret Brandwin Jessler classification, where they looked at PNI, worst pattern of invasion, and lymphocytic infiltration, and they gave the score from 0 to 3. And what they did was each of these were scored from 0 to 3, and a low score was 0, intermediate were 1 to 2, and high score was 3. And what they found was that when you have a lower intermediate score, the prognosis is better than when you had a high score. So basically what we are trying to do is, apart from a clinical and radiological assessment of early oral cancer, so we know clinically it is early, we need to define radiologically if it's early. If it's clinico-radiologically early after surgery, you need to know the pathology. In the absence of gross indicators of RT, you need to know pathological soft indicators, whether you would want to, whether this is really behaving like the early oral cancer, or this is a little more dangerous and can recur locally because of these other factors. So maybe 2 or more of these factors you would want to give radiation therapy. So to conclude, clinical diagnosis is the most accurate for early oral cancer. Adjuncts are an exciting area of research. T classification has changed with time. And the more importantly, this T classification has, because there is an impact on adjuvant radiotherapy. Now it's if you have more than 10 millimeter depth, you know it is T3, and it has legitimized our indication for postoperative radiation therapy. Radiology, there are specific indications where you do radiology. So a small T1 lesion of the buccal mucosa sitting in the center of the buccal mucosa, or a small superficial tongue lesion, I may not ask for any imaging, but the indications, as I showed you earlier, are there for doing specific investigations. And adjuvant therapy, there are some soft indicators in early oral cancer which need.
So first to Dr. Samir Patel, a quick remark for the first talk by Dr. Devendra Choukar. Over to Dr. Samir Patel.
Yeah, good evening, everybody. At the outset, I would like to thank the organizers, especially Dr. Reena and her team, to have invited me for this particular wonderful conclave. And having said this, I would like to congratulate Dr. Chaudhary for an excellent presentation, where he literally was absolutely pinpointedly giving us the information about how to diagnose the lesions as early. It can never be overemphasized. I mean, the role of early detection of any lesion. And the take-home message that we need to understand from his presentation is we really need to look at almost all the kinds of tests and the tools that we would have at our disposal before we finally come to a conclusion. And many a times we have to fall back to the diagnosis, the examination and palpation